see the stomach, we can see the duodenum, that where it leads to small intestines. You can see the cystic duct, okay? Let me see whether, can you see my arrow? You can see my cursor. This is cystic duct. Can you see it? All right, then common hepatic duct. This is a common hepatic duct. And then portal vein, right hepatic duct. This main liver, the liver. The left hepatic duct, spleen. You can see where spleen is. Hepatic artery, stomach, like I said, and pancreas. All right. What does liver do? Liver receives and processes and store amino acid. Isn't that the liver store amino acids? It store carbohydrates, it store lipids, vitamins, and minerals in the body systems. Okay. And it's also store plasma protein like alpha and beta globulin, coagulative factors, and transport proteins, as they are all synthesized in the liver. Plasma protein, alpha and beta globulin, coagulation factors, transport protein are synthesized in the liver. If the liver is badly damaged, you can see these important proteins, plasma protein, will not be able to synthesize. It won't be able to be produced by the liver. So that's why we need to guide our liver with all jealous. We must take good care of our liver, eat good food, take enough water, and make sure our body is in a good, healthy condition. I said the human liver is located in the upper right of the abdomen, beneath the diaphragm. The liver weighs about 1.3 to 1.6 kilogram in an adult. Like I told you, is the largest organ in the human body, the largest organ in the human body. And the functional units of liver are lobules. And these lobules are made up of hepatocytes. They are lobules, and these lobules are made up of hepatocytes. And these hepatocytes we have in billions. We have them in billions, hepatocytes in the body, in the liver, the liver cells. And it contains a network of blood vessels, if you see, just full of blood. That's why it's very proteinous. The aspect, we want more protein in the body, in the animal's body. Take the liver. Liver is very highly proteinous. Okay, why? Because it synthesizes all this plasma protein, are produced there. The ligament, like the falciform ligament, divide the lobes and attach the liver to other structures. Now, I want to look at major structure. What are the major structures in the liver? Major structure in the liver, number one, we have lobes. The liver is divided into main lobes, the larger right lobe and the smaller left lobe. A smaller posterior caudate lobe and inferior caudate lobe are also part of the structure, typically described as being on the posterior and inferior surfaces, respectively. Lobes, if you look at the diagram, you can see the lobes. They are there. The lobes can be found in the liver. And then number two, we have a segment. Each lobe is further divided into 8 functional segments. The lobe, segment, that is the lobe we mentioned, divide into 8 functional segments. We have lobules, like I told you, that's the most functional unit of the liver. Like in the kidney, the most functional part of the kidney is what? It's nephron. But in liver, lobus is the functional unit of the liver, and which they are small hexagonal structures. We have hepatocytes. Each lobule contains billions of hepatocytes, like I told you, billions. And the lobus in thousands, many of them in thousands in the human liver. And the hepatocyte each contain billions of hepatocytes, which are the basic metabolic cells of the liver. Key connection and pathway, we have blood vessels, we have bile duct, we have ligament, we have portal hepatis, yeah. We want to look at what's the function of the liver. Number one function of the liver is a detoxifier. It detoxifies exogenous compound, such as drug, such as toxin. There's a process called biotransformation. What happens? It converts lipolytic substance into hydrophilic one for subsequent elimination. So when you talk about biotransformation, what happens is that the liver it detoxifies. Like for example, if somebody taking alcohol drinks, maybe 45%, when you get to the liver, when you get from the intestine to the liver, when you get to the liver detoxify, it breaks down those components. in such a way that it won't be cause injury to the body systems. Okay. And then drugs, those people that took drugs, like me personally, ordinary even paracetamol we take in toxicology, about 30% of that paracetamol is not working, it's not do anything in your body system. They are residual. And what happened? Liver detoxify them. Personally, I don't like taking drugs. Even anti-malaria drugs, before I can take drugs, it takes them because the consequence of those drugs, it has an impact in our body systems. Okay. Now imagine people taking about they have illness taking about 13 tablets every day, morning and night, for 3, 4, 5 years. You can see the impact of those drugs on their liver. So what I will say is that the primary site for liver is the primary site for detoxification of toxin, of drugs. Okay, it is a detoxify. That's why you have to be conscious of what to put in your body, be conscious of what to drink and what to take, for us to live, a healthy life. 2, it conjugates bilirubin with gluconic acid to produce bilirubin monoglucorides, which are excreted by bile. It is a conjugate bilirubin. Okay, so that's another function of liver. It metabolizes carbohydrate too. Carbohydrate, lipid, protein, that is where the metabolism takes place. What is metabolism? Breaking down and building up for all these food components. Like there in the liver, there's glycogenesis. Glycogenesis, that is production of glycogen, from glucose. And then we have glycogenolysis, that is breaking down of glycogen. And then we have gluconeogenesis. Please pay attention to these keywords. Pay attention to this keyword. I'm repeating again. Glycogenesis. What is glycogenesis? Glycogenesis is breaking down of glycogen, into smaller components of glucose and other smaller components. Then glycogenolysis, glycogenesis, that's the building up of conversion of glucose to glycogen. Conversion of glucose to glycogen, that is glycogenesis. Why glycogenolysis, that is breaking down of glycogen into smaller components. And why gluconeogenesis, that's getting glucose from non-carbohydrate source, from fat and oil, from proteins during fasting. That's what is called gluconeogenesis. The latecomers are welcome. I think we have about 6 members now. You are welcome, latecomers. Then we have lipid metabolisms. Lipid metabolism, that is synthesis of cholesterol, lipoprotein, and fatty acid. When you talk about lipoprotein, talk about very low density lipoprotein. We have high density lipoprotein. We have low density lipoprotein, which is a bad cholesterol. Low density lipoprotein is a bad cholesterol. So all the metabolism take place in the liver. Also protein metabolism, synthesis of albumin, like we mentioned, as a part of in the liver, and then clotting factors and urea cycles. Another function of liver is to, as I said, detoxification and biotransformation. That's where liver metabolizes drugs, xenobiotics, via phase 1 and phase 2 reaction. It convert ammonia to urea for excretion. Detoxification takes place in the liver. Then we have bilirubin metabolism. Breaking down of hemoglobin produces bilirubin. That is heme and globin. When it breaks down, produces bilirubin. And bilirubin is conjugated in hepatocytes. Remember, hepatocytes is small cells in the liver and excreted in bile. Also, it has a exocrine function. Bile production, secretion aid in the fat digestion and absorption. If there's no bile, that we hate the fat will not be digested, will not be properly digested and absorbed in the wall of small intestine. Also, you have storage capacity, store vitamin A, D, B12, iron, and glycogen. And I want to look at clinical relevance in diagnosis. What are the clinical relevance of how is liver important in diagnostics? Liver, we look at liver enzymes, alanine transaminase, aspartate transaminase, alkaline phosphatase, gamma glutamate, GGT, key markers for liver function and injury. These 4 enzymes are key markers for if there's any injury in the liver. These are the key markers that can be used to diagnose them and to know the value, whether it's within the normal range or above the normal range. Disorders, conditions like hepatitis, cirrhosis, cholestasis, and portal hypertension are discussed, and they can be discussed and can be identified or diagnosed. Liver function test helps assess liver health by measuring enzymes, by measuring proteins and byproducts in the blood. Interpreting them requires understanding what each marker indicates about liver function or damage. I'm not doing much work, on this because I know you are experienced and experienced medical laboratory scientists. These are basic things you need to be aware of. The liver panel biomarker, want to look at what are the liver panel biomarkers. One, it includes enzymes. When you talk about liver panel, you talk about enzymes like what I've mentioned, ALT, ST, ALP, and GGT, proteins. Then what's product that reflect liver health. Each has a reference range, and deviation can signal specific liver condition. With the reference range, we know if result we get is within the normal or above, or is not in order. So we want to look at details guide to the most common liver panel biomarkers, their normal reference ranges, and what abnormal result may indicate. We want to look at the liver panel biomarkers. No, we want to look at the reference ranges. Where is the reference range? What is it normal or is not? It's abnormal. So we go to this liver panel biomarker reference range and interpretation. Can you see the slide? Are you seeing the slide I share?
Yes, sir. We are seeing it.
Am I audible enough? Can you hear me loud and clear?
Very, very clear, sir.
All right.
Yes, sir. You are clear.
All right. So let's look at the biomarkers now. I told you we have alanine transferase. We have aspartate transferase, AST, ALT ratio, alkaline phosphatase, gamma glutamine transferase, total bilirubin, direct conjugated bilirubin, albumin, total protein times. That is made the liver biomarkers. I can look at the reference ranges. ALT 7 to 56 microliter. Then aspartate 10 to 40, like that. Then if somebody is having hepatitis, what happens? High level may indicate when the level of ALT is high. It's above that 56, above normal range. That means there's a liver cell damage. Like if somebody is having hepatitis or fatty liver diseases, it could cause ALT to be, and it is rare. Low level may indicate rare, hardly get low level. In some very cases, may suggest severe liver damage if it is low, pretty low. Same with AST. If it is high, that may liver, heart, and muscle injury. It's not specific to liver alone. AST can be found is part of the enzymes, the liver and the heart, and then muscle injury. Then very low level may indicate advanced liver diseases. Now, AST-ALT ratio, if it is less than 1, that's not alcoholic cause disease. But if it is greater than 2, that means it's alcohol that caused that liver issues. When you find the ratio, AST and ALT ratio, when the high level in AST ratio may indicate alcohol liver disease. If somebody is when it is greater than 2, they consume alcohol for almost 10, 15, 20 years. The AST ratio may increase. Now, ALP, alkaline phosphatase. Alkaline phosphatase, when it is high, they indicate bile duct obstruction, bone diseases. It is low, malnutrition, hypothyroidism. Then GGT, the reference range 9 to 48 per liter. Then it is high. That's alcohol use, bile duct issues. Then total bilirubin 0.1 to 1.2 milligram per dl. It increases in jaundice, in liver dysfunction, and hemolysis. Direct conjugated bilirubin 0.0 to 0.03 milligram per dl. Bile duct obstruction, liver diseases. For those who are neonatal jaundice, we check most of those total bilirubin and conjugate to know the cause of their jaundice. Also, albumin, the range is 3.5 to 5.0 gram per dl. And if it is low, that's chronic liver diseases, malnutrition, or somebody is not properly fed. When the albumin value is low, the total protein 6.3 to 7.9 gram per dl. It increases chronic inflammation infections, and it reduces in liver, kidney disease, malnutrition, total protein. Then protopin time, that is 11 to 13.5 seconds. Reduce clotting factor when it is high. When it's above 13, that means the clotting factor is reduced. Maybe somebody want to go for CS. Most time they check PT, to know the clotting factor. If she don't be post-operative bleeding, So the clotting factor, when it is higher than normal clotting factor between 11 seconds to 13.5 seconds. All right. So how to interpret liver panel results? When we have elevated alanine and aspartate, that suggests, like I explained, hepatocellular injury. But AAT is more liver specific. That what means is that that is just like a gold standard. It's more specific. Alanine transaminase, that is more specific. So when we do liver function test, we must pay more attention on alanine transaminase, the value, very, very specific to liver. Why AST can be found in other, like in tissue, in the kidney, in the heart, and other muscles. But AAT is more liver, liver specific. The high alkaline phosphatase and GGT point to cholestasis or bile duct obstructions. While high bilirubin indicates impaired bilirubin clearance, common in hepatic or bile duct blockage. Low albumin or prolonged PT suggest reduced synthetic function, often seen in cirrhosis. Then AST-ALT ratio helps differentiate alcoholic liver disease from viral or fatty liver diseases. So we want to look at how do we interpret this results. Pattern recognition, hepatocellular injury. When somebody is having hepatocellular injury, that means the alanine transaminase is high and AST is high. Okay? Hepatocellular injury can be caused by viral hepatitis. Some people, they have viral infection. They never knew. Their eyes will be turning yellow. At a point after getting that viral infection for years, like hepatitis B, hepatitis C, the skin, they be going down. Their skin, they be degenerating and be reducing in size. Drug toxicity, some people that take a lot of drugs, drug addict, the AST and ALT is always high. Then cholestatic pattern. We have alkaline phosphatase, GGT, that is somebody is having gallstones, bile duct obstructions. It is expected that ALP and GGT will be high. Then mixed pattern, if either hepatocellular and injury and cholestatic pattern, the two of them, elevation in both set of enzymes, both ALT, AST, and ALP, GTT, both will be increased. Then severity assessment, we look at ALT and AST ratio. When it is greater than 1,000 units per liter, often acute injury, ischemic hepatitis, acetaminophen toxicity. That's when some people they can't do without taking paracetamol. Any little tiredness, don't take headache, small, they don't take paracetamol. In fact, their backs, every second they take acetaminophen, every time, And like I told you when we started in toxicology, I don't know whether you get, I think I can see, even though there will be topic we know to do in toxicology, some of these part of these drugs we take, some percentage are being detoxified in the liver, they are not used to the body system. So that's why it's always better for you. Maybe you are stressed out, maybe you have headache, just sleep and wake up, relax and have time to rest from stress to solve you a lot of drug toxicity in your body systems. Also, mild elevation may be due to fatty liver, alcohol, or medications. I've seen some instances, some people, they have been sick. I try to a lot of old age, they are taking like 20, 30 tablets every day, morning and night. But I don't wish that for my enemies. And I pray, God, Number three, we have synthetic functions. Synthetic function. When albumin is reduced and protein time is reduced, suggests impaired liver synthesis, cirrhosis, liver cirrhosis. What is liver cirrhosis? Where that's perforated in our kidney liver, there's a hole, in the liver. Then number four, bilirubin level. How do we measure bilirubin level? When we have increase in conjugated bilirubin, it means hemolysis or Gilbert syndromes. When conjugated bilirubin is high too, that means liver dysfunction or bile duct obstructions. What are the clinical context matter? The clinical context matter. 9, about 3 students are not yet joined. All right, no problem. Clinical context matter. Always interpret liver function test alongside symptoms. Each time you see the result, the clinician must combine, with the symptoms, for example, jaundice, fatigue, and abdominal pain. You always interpret your result alongside the symptoms presented by the patients. Also, history. Ask the patient, has he been taking alcohol? How long have you taken alcohol? Take the history of the patient. Medication, what are the medications you have been taking? What happened? What was the past experience of sickness you have, and what drug medication have you been taking? Then ask the patient if you have been exposed to virus. Okay. Then imaging and other labs, that's ultrasound hepatitis serologies, can also be compared. That is confirmation to be able to confirm what you found or the result gotten from the laboratory. Now, what is bilirubin? Bilirubin is a yellow pigment produced through the breakdown of red blood cells. We all know that red blood cells break down on every 120 days. Every breakdown, and it's being regenerated in the body system, in the body also. So bilirubin is yellow biopigment produced through the breakdown of the red blood cells, which is known as hemolysis. Bilirubin is metabolized prior to excretion through the feces and urine. We want to explore different types of bilirubin, the process of enteric bilirubin metabolisms, and we briefly explore the relevance of bilirubin to clinical practice. We want to look at the bilirubin. What is bilirubin? Bilirubin exists in two forms. We have unconjugated and unconjugated bilirubin. Bilirubin is insoluble in water. Okay, and then this means it can only travel in bloodstream if found to albumin. That means it must combine with proteins for it to be transported, to be moved, to be transported in the body, and cannot be directly excreted from the body. In contrast, conjugated bilirubin is water soluble, hydrophilic. This allows it to travel through the bloodstreams without acquiring transport protein like albumin. You can see the difference between conjugated and unconjugated bilirubin. Conjugated is water soluble, while unconjugated bilirubin is not what is water is not water insoluble. It's insoluble in water. So we want to look at the metabolic pathway of bilirubin in details. Creation of bilirubin. Bilirubin is being produced in reticuloendothelial cells that are responsible for the maintenance of the blood through the destruction of old abnormal cells. Like I told you, that blood cells, they die after 120 days. And it happens in reticuloendothelial cells, macrophages. They take up the red cells and metabolize the hemoglobin present into the individual component heme and globin. Globin is further broken down into amino acids, which are subsequently recycled. Meanwhile, heme is broken down into the iron and biliverdin, a process which is catalyzed by heme oxygenase. The iron gets recycled while biliverdin is reduced to create unconjugated bilirubin. Now, bilirubin conjugation now. In bloodstreams, unconjugated bilirubin bind to albumin to facilitate its transport to the liver. Once in the liver, glucuronic acid is added to conjugated bilirubin by the enzyme glucuron transferase. This form conjugated bilirubin, which is soluble. This allows conjugated bilirubin to be excreted into duodenum and bile. I want to look at bile excretion, how bilirubin is being excreted in the body system. Once in the colon, colonic bacteria deconjugate bilirubin and convert it to urobilinogen. You know that urobilinogen can be found in the urine. Around 90% of urobilinogen is further oxidized by intestinal bacteria and converted to stecobilin, and they excreted through feces. It is stecobilin which gives feces their color. Around 20% of urobilinogen is reabsorbed into bloodstream as part of enterohepatic circulations. It is carried to the portal vein where some of it is reabsorbed by the liver for secretion in bile, while a small percentage reaches the kidney. So if it gets to the kidney, here it's oxidized further into urobilin and the excretion into urine. You can see the heme oxygenase to biliverdin. Look at the picture to bilirubin. Bilirubin from bile duct, it gets into glucuronic acid by removal to form urobilinogen or stecobilinogen. Stecobilin, and then it goes through from the intestine, enter the enterohepatic circulation via hepatocyte system, see enter to convert it to biliverdin. This is an example of bilirubin metabolism. I may write short note of bilirubin metabolisms. You just give it the diagram and explain. You get 2.5 marks. Jaundice. Jaundice is described as a yellow discoloration of the sclera and or skin in response to elevated bilirubin level. It causes of jaundice can be categorized as pre-hepatic, hepatic, and post-hepatic. Pre-hepatic is caused by increased hemolysis. When there's hemolysis in the body system, like those would have sickle cell and sickle cell patients, the result is the increased presence of unconjugated bilirubin in the blood as the liver is unable to conjugate it all at the same rate. This is caused by tropical disease like malaria, yellow fever, genetic disorder like sickle cell, I mentioned, Gilbert syndromes. These are things that can cause jaundice. You can see all those SSS patients, see their eyes always yellow. You know, like jaundice, they always, because of hemolysis, they always have hemolysis. Then I want to talk about hemolytic anemia. We have hepatic jaundice caused by liver impairment. This causes the decreased ability of the liver to conjugate bilirubin, resulting in the presence of conjugated and unconjugated bilirubin in the blood. Liver damage can result from one, viral. There was one experience I had when I was working with NDDC. The NDDC will do project medical examination in about 9 Niger Delta states, where each time we go for the project, we get like a consultant, we get a surgeon, maybe 4 or 5 surgeons, medical doctor, MBBS, like 4 or 5, pharmacy, medical scientists. So there, they used to do free health missions. They will purchase drugs. That time it was about 11 million. They buy drugs, we do serial section, we do eye operation, so many things. As a medical lab center, I used to follow them, go. So before they do operation, we used to do basic medical diagnosis. So that's one of the pharmacists, it's a pharmacist is one of the major critical stakeholders. They careless just came to the lab and said, we want to do hepatitis. So we do hepatitis first time. The thing was positive. I said, what happened? So we repeated, stay positive. And the man never knew. That was almost about 15, 16 years ago. The last time I saw him about 2 years ago, if you need to see the man, because of that viral infection, the size are reduced. We were just growing lean, macheting, every now and then, So some people need to do thorough checkup for us to know, to diagnose ourselves, to know if we are healthy or not at every time. It's not when you are sick, you need to do diagnosis, you need to check yourself. All right. Hepatic hemolytic anemia. Hepatic jaundice is caused by liver impairment. When liver impairment, that means something is wrong, maybe liver inflammation, maybe cirrhosis, something is wrong with the liver if it's impaired. Maybe do alcoholism, maybe viral infection. A lot of things can cause liver impairment. This causes the decreased ability of the liver to conjugate bilirubin. So when liver is impaired, that means the liver will not be able to carry out its function properly, will be able to conjugate bilirubin, resulting in the presence of conjugated and unconjugated bilirubin in the blood. If the liver was unable to conjugate bilirubin very well, conjugated bilirubin be found in the blood. Liver damage can result from viral hepatitis. Viral hepatitis, the hepatotoxic drugs. There are some drugs that affect liver. They are toxic to the drugs. All those that take drug to body drug addict, it causes damaged liver because paracetamol overdose. All those people that take paracetamol, it's now. Acetaminophen, all these wheelbarrow pusher, all these people in the bad boys, they take overdose of paracetamol. They are cleaning their liver. They have strength. They be strong for hours, for like 10, 20 hours, 24 hours. It has a consequential damage effect on the liver. Alcohol abuse, I don't know how many of us have been to the South before. Ogogoro na water, ogogoro be mini. They drink, Thomas a party by. They drink just like in Europe. The first time I went to Europe, I saw where they are doing from Wednesday, Thursday, Friday. Party new, club, they never go, they want to enjoy my day. They are damaging their liver. Now, we want to look at post-hepatic jaundice. What is post-hepatic jaundice? Caused by the blockage of the bile duct. If you look at the bile duct in the picture, the first picture I projected, look at the bile duct. If there's a blockage here, can you see it? Are you seeing the bile duct? So if there's a blockage here, it affects so it causes post-hepatic. That's after it has left the liver cells. Post-hepatic jaundice caused by a blockage of liver, bile duct. This results in backflow of conjugated bilirubin into the blood as it cannot move past the obstructions. The bile duct obstruction can cause by gallstones. Maybe there's a gallstone blockage in the bile duct. Hepatic tumor, if there's a tumor, inflammation of the hepatic cells. Then pancreatic tumors. In the pancreas, we have enzyme insulin and glucagon. Pancreatic tumor can cause it can cause post-hepatic jaundice. And this last one, Gilbert syndrome. Gilbert syndrome, bilirubin conjugated in the liver. Gilbert syndrome is an inherited disorder. It's what is it called? Inborn. It's just like an inborn error. Syndrome is an inherited disorder characterized by hyperbilirubinemia, excess bilirubin in the bloodstreams due to mutation in UGT-RA1 genes. When we talk about mutation, I will discuss mutation, that the exchange in nucleotides. If the set of nucleotides A, B, C, D, and the control is a CDB, if there's a mutation in the gene in the nucleotides, that's what they call this particular gene, it leads to deficiency in UDP glucosyltransferase transferase. These 4 genes result in slower bilirubin conjugation in the liver. So it builds up in the bloodstream instead of being excreted through the biliary duct. Patients are usually asymptomatic and have normal bilirubin level. However, under physiological stressors such as illness, alcohol abuse, and extreme exercise, patient can become markedly jaundice. So this, because it's inborn error, is now well noticed. When you do the bilirubin level, it will be normal until maybe the person is undergoing stress, maybe play football, do exercise, then there'll be remarkable jaundice. And this is the end of the lecture. So help me God.
Thank you so much, sir. Very fast.
Thank you, sir.
Do we have questions?
Who is there?
Let me see. Who was not in the class today?
We don't have Madam Okola, Mr. Olagudu, Mr. Wasiu is not here. Don't know.
Okay, Mr. Akanji, Mr. Akanji, my director, sir.
Yes, sir.
Yes, in class now.
I'm very sorry, sir. I was about not being in class today again. I've never experienced clicking on a Zoom link and then the Zoom link will be asking me for passcode. Automatically, it just goes. So I now decided to go and copy pass link myself and type it in. That's how I joined late.
Yes.
15 minutes I had been trying. But yesterday, it didn't occur to me that I was supposed to copy the link and I couldn't join throughout yesterday. I'm very sorry, sir.
Okay, so I think you've got the lecture note for yesterday.
Yes, sir. I'm talking with Mr. Fasasi to get that, sir.
Okay.
Yes, sir.
Director Stella, okay, Mokinyo.
Thank you, sir. Happy Sunday, sir.
God bless you. There's some people, they never miss class. There's some people in this class, they never miss my class. Never miss. Please, let us try. Where is okay, fine bone is there. Madam Kinoniwa. Yeah, go don't play golf. I go work class. Okay. So do you have any question, please?
I don't know why Mr. Wasi is not here. It's unusual. So it's always
It's always
But-
there.
It's always here.
Okay. Any question? I want us to before the year runs out, as I said, most of our topic we do with them, and then we can be able to have revision. And your exam is coming. The exam is next year. Next year exams, February or January or February, long. So I want us to finish ahead so you can have your time, to read through and then be able to go through. So, in absence, no question, any contribution from our colleagues, when I lecture, me too want to learn. Most of you have been practicing on the bench. You can share your experience, so we can, all of us together can pick, one or two things. If there's any contributions, comment, observation from your experience so far, the floor is open. In the next 5 minutes, let's discuss. Let's have interaction. Let's have conversation. All right. Anyone?
Hello, sir. Good evening, sir.
Good evening, sir.
This is Karim calling, sir.
All right.
Sir, yes, I've observed that I've seen some patients on some antihypertensive drugs like amlodipine. They used to have elevated liver enzymes. I think I have about 2 patients that came, after the investigation. On getting to that doctor, the doctor complains that the liver enzyme was not like that before. It later now asked that have you been on any medications? Now discovered that it has been on amlodipine. So later now change it. So all the liver enzyme now came back to normal, because if the doctor has not really probably not observant enough, probably could have interpreted to another thing. So that's what I've seen based on my interaction with some of the patients with the use of amlodipine as a drug for treatment, sir.
Okay.
And also, you are talking about ALT and AST ratio, sir. I don't know, maybe is what we call a diuretic ratio, sir.
Yes.
Okay. Thank you.
You're welcome.
Yes, sir.
Okay. Oh yeah. Now, any more interaction? Share your experience. Yes. My director, Mr. Akanji. Mr. Akanji.
Yes, sir.
Oh yeah, share experience here now. Ten parts.
Thank you very much, sir. I just want to add to it because after I became head in Kempat, I decided to introduce weekly lab round discussions where we pick funny results throughout the week to discuss. And liver enzymes has been a very stubborn one. Liver enzymes that will not agree with the clinical diagnosis of the patient, whether fatty liver disease, whether alcoholic liver disease, whether viral hepatitis. A lot of patients will not have any of these conditions, and then you look at their AST-ALT ratio, and it will still be funny. Mr. Rahim Karim that spoke earlier has now, yes, Karim, he has thrown light on one of the possible reasons we have for it, because our lab forms doesn't have a clear-cut place where you indicate the drugs you are on. And one thing we again now concluded in the think tank we always have in the department is the herbal mixture. The herbal mixture we have in town, Faji, Flusher, Pakurumo, all these things people are consuming. You will find that people are not on drugs, but when you now interact with them on giving out the results, you find out that most of them will agree to using one herbal mixture or the other. And it's always disturbing the differential diagnosis or the prognosis that should be made from lab results using liver enzymes. That's the little thing I may want to chip in, sir.
Thank you so wonderfully. You can see the experience counts. Thank you so kindly. Any further information, review, or to share experience in the next 1 minute? Anyone? All right. This weekend we won't be having lecture. I'll be traveling to, I'll be unavailable this weekend. So hopefully by next week, is it possible for us to be having lecture within the week? Any possibility? The class is open. Please unmute yourself.
Yes, I think it depends on the availability of our people.
Mo fẹ́ wo time tí àwọn pé most of us are worker. I want to see if any possibility, maybe 7 in the night, or I don't know the time that will be convenient for us. Well, no problem. Well, the matter of can stick pẹ̀lú weekend, we see what we can do. We include Sunday, Saturday, Sunday, and then.
I may want to contribute on that, sir.
Go ahead, sir.
Yes, thank you. In some other classes we have heard earlier, we find out that during the week classes are even sometimes preferable to weekend classes. The socio-economic belonging of the cadre of people in class now makes their weekend very busy, and they prefer weekdays. Now, the weekdays, the problem with weekdays is differences in people's itinerary. Some people think Monday is free. Some people think Wednesday is free. Some people think Friday is free. Some people think immediately after work, 4 p.m. is okay. Some people think it's when we get home at 7. Some people want to sleep at that time. The way to go about it from experience is for class governor, Mr. Fasasi, to conduct an opinion poll.
Okay.
We can conduct an opinion poll. A Google form will help us out. So
Okay.
after we log out of the lecture, he sends it and say, do you prefer weekday to weekend? Do you prefer 4 p.m. to 7? Monday, Tuesday, Friday, pick days you are free. If you allow us to run such a poll, we may be able to come out with a good day during the week. Thank you, sir.
Thank you. That is fine. That's fine. So over to Mr. Fasasi. Fasasi, please do that and then refer back to me. Okay?
Noted.
So if you prefer, if we just put weekend also, anyone, we look at the percentage, if we have more persons, but for me, weekend is a bit free for some of the weekend. I know now in November, December to January ending, there'll be party almost every weekend, one portion or the other. So please conduct the polls and then refer back to me.
Noted.
All right. Have I sent this lecture note?
No.
Okay, I will send it right now, right away. Let me send it right away so you can have the lecture notes. Thank you. Do have a wonderful day.
Same to you, sir. Thank you so much, sir.
All right.
Thank you, sir.
Thank you, sir.
So, my people, what about our contributions for the Zoom? We are whining and dining on credit. Hello.
Sir, the last post I saw was that Mrs. Okunla should make her.
I don't know. Yeah, she has not even responded. I don't know, but that's the best way to do it so that she can coordinate and you can relate with me. She still remains the assistant class rep. So I don't know. I have to reach out to her. Then Mr. Karim can help us with that since you are both in the office.
Yes, I think I'll meet with her tomorrow. So
please do so.
I think yes, somebody needs to conduct it, and then we need to be committed. I just want to encourage every one of us to let's abide by these rules, and then once we have able hands who are ready to sacrifice for us. So my prayer is that thank you.
Then I also want to encourage us, our lecturers. We have not been able to get hold of Dr. Akintaju and I think Dr. Anima Chan, if I'm not mistaken. I think it's the one with Lay City. I don't know. Please, if any one of us have direct contact with these people, please.
Also, we don't even know who's taking what.
Yes, we don't really know. So that we can prepare our mind. It's not like everything. The only person we've been seeing that is constant is Dr. Oni.
You know that we had the same thing, the same problem with Dr. Akintaju last semester, if you could remember.
And if we continue to have this, possibly we should just share the topic. We are all part. Let's just share the topic and take it ourselves.
Exactly.
There's no big deal in those topics.
Because you know that it was in the last hour that she started rushing his lecture.
So that we are not rushed. We are not rushed.
At least we should be able to know which lecturer is handling what.
Exactly.
They just give us a blanket.
What I need to do is just maybe discuss with Dr. Oni so that we know which one is taking us actually. So that if Dr. Akintaju and Dr. Amuson are not forthcoming, we'll just share the lectures. Everybody on the call are parts. So I don't think chemical pathology should be an issue for any one of us. And I know most of us are great teachers in our different respects, so that we can take it just like a tutorial. Yes.
Exactly.
So
good evening, everybody. Mr.
Yes,
Mr.
ma.
Patasi.
Yes,
Good
ma.
evening. You know, Mr. Amuson is my supervisor. Hello.
Yes, we are with you.
Okay. He's my supervisor, so I've been able to reach out to him concerning
Is it the one
project.
Is it the one at Lee City? Is it the one with Lee City?
No. The one with Lee City is UCH or Oga of hematology.
There is another. I think there's another Dr. Amuson.
This is not. Well, I didn't probe further to find out where he is. Sure, you understand me? It was on WhatsApp we talked, and then he asked me. He said, "Lectures, how far?" I said we've only. I said we've only had Mr. Dr.
Okay, he's working at Abeokuta.
Yeah, I guess so. Timothy Amuson. I'm not really sure. But there is one of us that is working with the states, Ogun State. It's Timothy Amuson. I guess so.
Okay, sir. I'll find out more details. He's my supervisor. So I asked him, he asked me that Dr. Oni has started. I said yes. He now said which aspect of this. And now I remember that Dr. Oni posted a breakdown of the courses. He's on that breakdown, he's on the platform there, on our chemistry platform. He posted it earlier. Yes, and probably I'll scroll through and then repost.
It will still be there.
Yes, on that platform, with what I have on me, it was CPH 501, Chemical Pathology 2 is for Dr. Akintaju. Then Chemical Pathology 3 is for Dr. Oni. Clinical Enzymanology is Dr. Oni. And then Nutrition and Clinical Vitaminology is for Mr. Amuson. He posted it, yes.
And then
you scroll through,
when we are sure what is going to take us, then help us to relay
platform.
Yes. I'll go through it and do it. I'll do that now. I'll do that.
Okay, thank you.
Thank you so much. We will appreciate
that. It will help our rep to do the follow-up.
So then you probably have to share his contact with me too, so I can talk to him.
You were the one that gave me his contact.
Am I the one?
Yes.
Hey, don't
when I was crying that
you
I
can
don't know
give
my
his contact
supervisor.
to Patasi now. Mrs. Finebone.
Yes. I think she said I'm the one that sent him the contact. I possibly got it from the dean then.
And let
yes, you did. You got from the dean.
Contact with you. Or with us.
Okay, no problem.
Okay, with everybody, so that people can also get across to him.
Yeah, because he said how many of us are his students, and I gave him the 4 names that picked him, and that was where we stopped. So I don't know. I only know that myself and
you are a student to be supervised, not a student in the class. Everybody is a student.
I know. I told him. He asked that how many students is he supervising.
Based
on the poll now we pulled that poll. Yes. So I now gave him the other 2 names, and that was where we stopped. Shall we've not I've not reached out
That's
to him
okay,
this
ma.
week.
Okay. That's okay, ma. We'll
So
do a follow-up. I will also do a follow-up with you.
Okay.
Thank you so
All
much.
right. You're welcome. Good night, everybody.
Good night.
Good night, all.
Sir, your line is breaking. Me, boy, that, sir. Hello, sir. Okay, I think it's off. Okay. I'll probably give him a call. So good night, everybody.